Hello and welcome to the City Club of Eugene's February 25th, 2022 program, Racism in Medicine. This is the 21st program of our 2021-2022 programming year. My name is Karin Knutson and I am City Club's president-elect. It's a delight to be here with all of you today, sharing this time and this important conversation in our community. Support for the City Club is provided by our members and sponsors. You can become a member of the City Club at our website, cityclubofueugene.org. This program is both live streamed and taped, and our programs are always available on our YouTube channel or our Facebook page, as well as podcasts, wherever you listen to podcasts. Programs are also broadcast on public radio station KLCC 89.7 on Monday nights at 7 p.m. City Club has both business and in-kind sponsors. Our diamond sponsors are Kaiser Permanente, University of Oregon, Peace Health, and Lane Community College. And we receive generous support from the City of Eugene and Lane County. Our format today includes a question and answer period with City Club members and non-members alike via live stream and text. If you'd like to submit a question, the text number is at the bottom of your screen. Our speakers for today's program, Racism in Medicine, include Dr. Derek Duvivier, MD, MBA from Oregon Health Science University, Dr. Crystal Crooks from Oregon Medical Group, and Siobhan Kenzel from Siobhan Solutions. And we have a first questioner from Kiana Kabuko, MBA of Lane County Medical Society. Biographical information about our speakers is available on our website, cityclubofueugene.org. And I would like to thank Joel Corin for coordinating today's program and also invite him up to introduce our discussion. Joel.
Thank you. In every study of who gets health care, it appears that people of color are less involved with the medical system than white people. What are the reasons for that? Some may point to the Tuskegee experiments. Some may point to the immortal life of Henrietta Lacks. What are the reasons for that? But not only patients are hurt by the discrimination in the medical system. A couple Saturdays ago, I was reading the paper, and there was a large article, Nurses of Color Fight an Open Wound. That same day, something appeared on Huffington Post, I'm a black doctor, and I got death threats for speaking about racism, and it gets worse. Today we're going to hear about racism in medicine from the perspective of a patient and a physician, and of a physician who is in charge of the DEI program in a large institution. Our speakers in order of appearance are Siobhan Kenzel, who is the head of and founder of Siobhan Solutions, which provides listening opportunities and dealing with issues of equitable and inclusion, equity and inclusion. Our second speaker is Dr. Crystal Crooks, who is a family physician at the Oregon Medical Group. And our final speaker is Derek Duvivier, a board-certified anesthesiologist from Oregon Health Sciences University and director of their DEI program. Siobhan, would you start us off?
Thank you, Joel. My name is Siobhan Kenzel, and I would like to start off by saying that my family actually has quite a few doctors in it. And even growing up that way, I am still a little bit mistrustful of our medical system. I was pretty sickly growing up, in and out of hospitals multiple times a year for one thing or another. I was diagnosed with asthma, allergies, skin infections, and even have been hospitalized 3 times for anaphylactic shock. Every time that I would go to the hospital, it wasn't necessarily about treating me so much as giving me more medicine. And it seemed like it wasn't until I was older and I was actually able to advocate for myself that I could get all of my doctors together and have them talk. And we came up with a really good plan. They started me on an elimination diet, which solved very much of most of my allergies, asthma, and skin issues. And I just think if I hadn't have had to go through those 26 years of being in and out of hospitals multiple times a year, how my life could have been very much different. I feel that sometimes when I walk into a doctor's office or into a hospital, that I'm not looked at as the person I am, but more a compilation of the medical problems that I have. And I'm not often heard when I speak to my own history. Speaking of history, it's not just me who is distrustful of our medical system. I know many of my family members do not go to the doctor. They would much rather wait and see if they can figure it out in their own way. And when that happens, you know, it can get immensely worse, and sometimes people pass away. Doctors, at least in my opinion, think of us in a different category. One example would be that I've been told I have a higher tolerance for pain than other patients. Another little interesting fact, excuse me, is P.T. Barnum. I don't know if everybody knows who that is. Did a lot of entertainment in the circus. I just found this out recently. Someone who used to go to the circus quite frequently and thought it was so cool with the tigers and the people on tightropes. But P.T. Barnum's claim to fame was that he did a dissection of a black woman that he falsely claimed was over 150 years old and charged admission to the dissection. And that was his first entertainment experience. Another example in our history that touches me deeply is back at the turn of the century, there was many young black boys that were imprisoned. And they were experimented on solely to find if they had the double Y chromosome. And I get that we have to do testing, but these kids were subjected to horrors. And the data was skewed, so there was really no reason to do it. So I have to think, where do we go from here? How do we make change? I think that we could examine the curriculum that is being taught in our medical schools. I think that we could make sure that doctors, in order to complete their residency so they can go practice medicine, that they have to do it in an underserved community. I also think that it would be really good for doctors to explore different disciplines instead of staying so focused in the one that they are, because maybe then I wouldn't have been seen as a bunch of diagnosed issues. I could have been seen as a human being. And of course, active listening. I can't tell you how many times I've looked into a doctor's eyes and watched them glaze over because I can tell that they're either not listening or maybe this is the 15th time that they've heard this ailment today. We have to meet the patients where they're at. And then with this current climate that we are in with the vaccine, it's kind of a catch-22. We want to have a more diverse group of people to test the vaccine on so we make sure that it's working for everybody. However, the people that would help make it a more diverse group have been horrifically mistreated by the medical system. So that's kind of where my head ends out, is how do we make it so the medical system can really be inclusive for all? Thank you.
So I guess Good afternoon. It is a pleasure to be here at the City Club of Eugene, and I'm very excited to be here to speak with you. And I have so much I want to share with you, but I have very limited time. So let me just cut to the end, and then we can start from the beginning, because there is one message I want to make sure you leave with, and it's just a one-word message, and that is empathy. I am here to share and hear new stories. And I am sharing stories and learning from others because it is my hope that this will allow me to become better in my ability to practice and exhibit empathy. And it is through empathy that we develop the ability to care about the well-being of others and to develop and show compassion. And I think we can all agree that the world could do with a lot more compassion and concern about the well-being of others. So I think I have about 9 minutes to talk about racism in medicine from a historical perspective. I have to admit that these last few weeks, I have woken up at night panicking, trying to figure out how am I going to deliver this message in 9 minutes. And as usual for me, I procrastinated. But in the same vein, procrastination paid off for me, because I only had to wait for the news to deliver my talking points. On Wednesday, in the New York Times, there was a headline: "The chair of Columbia University's Department of Psychiatry suspended." The suspension effective immediately. And it was because he referred to a dark-skinned model as possibly a freak of nature, and sent a message on Twitter to that effect. He was quoted as saying, "Whether a work of art or a freak of nature, she's a beautiful sight to behold." This is the department chair at Columbia University, Dr. Jeffrey A. Lieberman. And he tweeted this on Monday in response to a photo of Nayakim Gadwich. And I apologize if I have mistakenly pronounced the name. He was also permanently removed from his position as psychiatrist-in-chief at the Columbia University Irving Medical Center, New York Presbyterian Hospital. And he promptly resigned his role as executive director of the New York State Psychiatric Institute. I don't think I really have to point out the racist and sexist nature of this quote. This is a classic example of the fetishization of black women, which we see every day in print and social media. It is worth noting that the American Psychiatric Association issued an apology in 2021 for its part in perpetuating structural racism and enabling racist practices in psychiatry. An historical note, Dr. Benjamin Rush, who is commonly referred to as one of the fathers of modern psychiatry, believed that black skin was caused by leprosy, and a cure would change dark skin color back to white. One cure was thought to be depletion or bloodletting. I can only, imagine, you can figure out that if you're exsanguinating, what happens to your color. Rush even supported the experiments of Dr. Beddoes, who conducted human medical experiments by applying muriatic acid to black people's skin in an attempt to lighten their color. This belief that blacks are physically different can still be found in modern medicine. A study published in the Proceedings of the National Academy of Science in 2016 supports this. In this study, a survey of 222 white medical students and residents, as a result of the survey, about half endorsed false beliefs about biological differences between blacks and whites. Let me just repeat that. 2016, 222 medical students and residents, half believed in false beliefs about the biological differences between blacks and whites. And those who did also perceived blacks and whites, and those who did also perceived blacks as feeling less pain than whites. I think we've heard this theme. And were more likely to suggest inappropriate medical treatment for black patients. And this is all in the survey, the study, and the proceedings of the National Academy of Sciences. And let's remember, these medical students and residents are going to become attendings, researchers, physician leaders. Other false beliefs that were that were mentioned in the survey were that blacks' nerve endings are less sensitive than whites. Blacks age more slowly than whites. Whites have larger brains than blacks. Black skin is thicker. Whites have more efficient respiratory systems. And black couples are significantly more fertile than white couples. 2016. We also see the legacy of these false beliefs in the use of race correction in clinical algorithms. These corrections are based on the premise that black people differ physiologically than whites. The one you may have read about in the news recently is the use of a corrected factor for the estimation of renal function. Another includes a correction factor for pulmonary function. And as you can see from the proceedings of the National Academy of Science studies, these assumptions have real-world implications with respect to care given to people of color, resulting in the creation and perpetuation of health disparities. There's a great article in the New England Journal of Medicine that I would suggest you read. It is called Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. Lest we think that this is just about a few misinformed or poorly educated medical students or residents, I would like to bring you back to June of 2021, when the top editor of JAMA resigned due to the production and distribution of a podcast where, according to a New York Times story, a deputy JAMA editor said, quote, "Structural racism is an unfortunate term. Personally, I think taking racism out of the conversation will help. Many people like myself are offended by the implication that we are somehow racist." This podcast was supported by a tweet from JAMA that said, quote, "No physician is racist, so how can there be structural racism in healthcare?" It should be noted that the Journal of the American Medical Association is editorially independent from the AMA, which said that comments made during the podcast and the tweet were inconsistent with the policies and views of the AMA. Finally, I want to call out a recent article in Stat News. The title, "The Whitest Specialty. As medicine strives to close its diversity gaps, one field remains a stubborn outlier." According to the authors, less than 2% of those practicing in the field of orthopedics are black, just 2.2% are Hispanic, and 0.4% are Native American. Even Asian American physicians, a group considered overrepresented in medicine, are much scarcer in orthopedics, making up just 6.7% of these specialists. This is where I now introduce the Flexner Report of 1910. This report was supposed to address quality in medical education, but ended up decimating black medical schools. These schools were the primary producers of physicians who took care of black patients and also poor whites. As a result of the report, out of 7 black medical schools that were in existence at that time, only 2 survived. And these 2 schools were directed to emphasize hygiene instead of surgical specialties. Today, the impact of this study is widely seen in medical education. So what does this have to do with the racism that health caregivers experience? Well, I was a black man before I got my white coat. And now that I have that coat, it comes with the sad realization that it's not a shield. Modern medicine is not that modern. And in practicing medicine, I often have to deny my lived experience. I am asked in some cases, told not to believe what I see and feel. I work in a profession with peers and colleagues who don't necessarily have empathy for me. I work in a profession that utilizes a social construct, race, and the development of treatment algorithms that are not grounded in science. I work in a system that, when it does acknowledge disparities, asks me to be patient. And if you don't believe me on this point, think back to the beginning of COVID-19. There was a collective outcry about the disproportionate burden of disease. True. There was the pulling back, quote, the pulling back of the drapes, hiding health disparities in communities of color. Those disparities have been long-lasting. And I have to tell you, I wasn't moved by this collective raising of consciousness. Because in 2002, the year I entered practice, the year I finished my residency and moved to Southern Oregon to practice, there was a landmark 764-page report titled Unequal Treatment. From the report, quote, racial and ethnic minorities experience a lower quality of health services and are less likely to receive even routine medical procedures than are white Americans. Nothing much has changed over the course of my professional career. And so I ask, how much longer do I have to wait? Thank you.
We'll now hear from Dr. Crystal Crooks.
Hello, my name is Dr. Crystal Crooks. I work here in Eugene with Oregon Medical Group. So my perspective today is about experiences I've had as a Black physician. That being said, it must also be noted that I am a woman and I am an immigrant. So it is difficult to pass out the experiences that I've had as to determine whether it's because I'm Black, because I'm a woman, or because I'm an immigrant. When I first heard the word misogynoir, it blew my mind because it's the intersection of being Black and female, and it is a sight to behold when you are on the receiving end. So some of the instances I've had when I was a resident, and a senior resident at that, which means I'm no longer in my first year of residency, I would do rounds, which is where I go to see my patients, and sometimes there'd be medical students with me or junior residents, and a lot of them were white males. And I would go into the room and talk to the patient, let them know what the plan for the day is, and typically their eyes would just slide off of me and look over to the male junior resident or medical student to get confirmation, or ignore me completely and ask them questions. And that was very disheartening because I've worked hard to get where I am, and to be discounted just because I am a woman or because I'm Black and don't fit in the mold for what is typically seen as a physician is painful. I was constantly being mistaken for a nurse. Even when I wear my white coat, I would go into a room and people would ask me to move trays or get them off of a bedpan when that is not what I'm doing. I was a nurse for 10 years, so I don't mind doing it, but that is not why I'm here today. I have experienced numerous times that people try to call me by my first name. In medicine, most male physicians get addressed as doctor. I remember reading a study that said women physicians typically get called by their first name. So besides being Black, I feel like I have to cross another hurdle to demand respect, even within my own field, as a female. I always have to wonder when instances like these happen, if they would do it to a white male colleague, where they would doubt what they say or address them so informally. It is difficult having to suppress my humanity, my identity to take care of patients. When I worked in Tennessee, there was more than one time when I had to take care of patients, even though they called me nigger or they were tattooed with swastikas and making threats to me that if I don't do what they want, they will find me. And it's scary. It's, but I still had to deal with it and do the best I could for them, even though I was terrified and I felt dehumanized. I have read many instances about other physicians of color who have had to deal with things that our white colleagues typically don't. For example, I remember reading about a physician in the Midwest who had COVID, and she was telling other physicians that there was something wrong, that she was really sick, and no one listened to her, and then she died of COVID. I remember reading about on a plane, someone requested a physician, and a Black OB-GYN resident, which is OB-GYN resident, stood up, and the nurse was like, "No, darling, we don't need a nurse. We need a physician." And other cases where physicians of color have to prove their credentials by showing their license, which I don't typically have on me. I leave it in my office. I remember reading even about physicians being asked by patients to prove that they can read, to prove that they are a doctor. That being said, there are other instances of racism that I have experienced, which it happens practically every day. It's a very general sort of racism that gets passed along. For instance, I've been told that I'm not Black because I don't look like the way some people picture someone who is Black, which of course makes me feel less than, because I know my identity, you know, I know who I am, and other people do not get to tell me who I am. But yet there are a lot of people who feel the need to try to put me in a box. I've had patients ask me, "What are you?" To which I inevitably respond, "Human," but they don't seem to get the joke. They are determined to try to pin down my ethnicity and don't want to listen to who I say I am. I get asked to have my hair touched because people want to know what it feels like, which is also part of the endemic racism. So the racism we experience outside of medicine is brought into medicine, not just from other providers, but also from patients who are not accustomed to seeing people of color, especially people who identify as Black or Latino in the healthcare field. And so we have to deal with their racism towards us while dealing with other people's racism towards us. And also understanding where people of color come from with their experiences with the healthcare system also. Thank you.
We will now take a short 5-minute break. Thank you. Our first questioner today is Kiana Kabuko, who is head of communication and DEI at the Lane County Medical Society. Kiana?
Hello. I have a two-part question. So how can we support and encourage more people of color in the medical field, especially in communities where minorities aren't inherently represented? And how can we create environments where we're able to recruit and retain more diverse populations of healthcare providers who can then help generate more trusting relationships like Siobhan had mentioned?
Dr. Duvier, do you want to start?
Sure. To the first part, I think that being what is commonly referred to as an ally is an important step. Sure. So one of the first things to the first question is being an ally, and that's, for instance, being willing to step in to situations where you see expressions of explicit or even implicit bias. So for instance, at OHSU, we are beginning a program called Stepping In, where folks are trained on how to interject themselves into situations where bias is being displayed, how to diffuse the situation, potentially distract folks from continuing the bias. So being able to advocate in that way, I think is important. But even with doing that, I think it's also important to also check in with the person of color. I can tell you that in my experience, when I was on the wards, when I was training and something happened, oftentimes I didn't want anyone to step in. I didn't want anyone to raise a problem because they were going to disengage, they were going to leave, and I was going to be stuck with whatever came down the pipeline. So oftentimes I just wanted to absorb it, put my head down, get through it, fly low under the radar, get to the end and get out. So it's important I think, to check in before you step in. And the second part was?
How can we create environments where we're able to recruit and retain diverse healthcare providers to help with building trusting relationships like Siobhan had mentioned?
So I think that an important thing here is to listen what the healthcare providers say, to believe in the stories, so many times I was told, well, they might not have meant that, or why are you thinking that way? Why don't you just assume good intent from the beginning? Believe the stories and have some empathy. I think that's the beginning of how you can create an environment that is that's nurturing for providers of color.
Siobhan, do you care to respond to that question?
First, I would like to say that I am not a doctor. So more to the second part of the question, I think that it's maybe making it a little bit more accessible to students, letting them know that, becoming a doctor, what I heard growing up was that, oh, you have to go through your 4 years of college, and then your 4 years of medical school, and then your 8 years of residency, and then maybe by the time you're 55, you might be able to practice. So it might be better if we can get some of these younger kids who have already a more open mindset and are dealing with things that we're just starting to kind of grasp now, get them into the medical field, let them start talking to patients, and have the financial backing so it doesn't put them in debt and their families in debts for the rest of their lives.
Dr. Crooks, do you have a response?
Yes, I would like to say mentorship, I think, is key. I know granted, I am a non-traditional student when I went back to medical school, but I did not know where to go for information. I was lucky enough to have people to help me out, but without those people, I wouldn't be where I am. And I think for a lot of minorities, it's that you don't know anyone who is a physician and you don't have the resources to ask questions. So I am a huge fan of mentoring BIPOC students so that they know how to go about the process. They know that there's someone who went through that process and has reached where they aim to be. Another thing I want to mention is that I was reading an article in some magazine that there has been a higher admission rate to medical schools since the advent of COVID, because most of the interviews that are done for medical school now are done using Zoom or something like Zoom. And the reason that has helped with admission is that BIPOC folk tend to typically come from a lower socioeconomic background than the people who are Caucasian and want to become physicians. And with Zoom, they've taken away the ability or the problems that people had with getting the money to travel, because it is expensive when you're applying for medical school. You have to go to actual in-person interviews in all the places that you potentially want to go to medical school. And you need to apply to a lot because to up your chances of getting admitted. So the Zoom factor has actually helped with defraying a lot of the cost that would make it disadvantageous for BIPOC folks. So I hope that continues because that is also really helpful with bringing more people in.
Thank you, Cam. Next question will be from Karen Knudsen.
Hi, thank you all very much. Karen Knudsen, she, her pronouns, and City Club President-elect. My question has to do with something you both mentioned about our assumptions and norms and norming to Caucasian skin. And I read in December that a Nigerian medical student and illustrator named Chidibe Ebere Ibe had made the first illustrations, anatomical illustrations, that included dark skin, that in less than 5% of medical illustrations is dark skin represented. And he had made these beautiful drawings, I believe mostly of pregnancy, to show a black child growing within its mother. And I'm just curious if you could say something about what the medical profession and the medical educational profession is doing to change how we present norms of the human body so that more people feel included in medicine and in what can be fairly scary circumstances.
Yeah, that's a great question, and I was actually familiar with that story. And there's been a lot of that's a relative term, attempts to improve medical school curriculum along those lines. And a great example that I can give of this is that we use pictures of certain pathological states in our lectures. And there's a movement to diversify those pictures to include pictures of people with dark skin, because the physical manifestations may be very different, appear different in darker skin than what you're normalized to with the white, with a picture of a white person. So there are efforts to absolutely do that. There are also efforts to diversify patient populations or simulations with patients so that that medical students have the ability to encounter a very diversified patient population. But that's definitely a very good point. The medical school, the anatomy atlas that we used was Netter, and that is kind of the gold standard, and it's never changed, at least not that I'm aware of. And so there are definitely efforts along those lines, but it's still a very slow go at it. Siobhan?
You know, I think that representation really matters, and we can't know what we can't see. And to be able to have that representation in our medical school's curriculum is going to provide a deeper level of understanding in the diverse population that they may serve. I would also like to say that it seems very interesting that sometimes in the medical community, especially in the historical past, that we are perfectly okay with utilizing black and brown bodies and their cells to advance medicine. But when it comes to looking at the person as a whole, that is when we shy away from that representation. Thank you.
Dr. Crook?
What I have seen is that one of the resources that I commonly use, it's called UpToDate. It has all the things, and it's typically updated with the most recent recommendations. And I have noticed an interesting trend in the past year that when I look at skin conditions, especially, there is now a section that is dedicated to what certain lesions may look like on black skin, because it will look different than it does on white skin. And I really appreciate that. I am also, I also think that the studies that are being done will help. I know that for Oregon Board of Medicine now, you have to do a cultural competency test every year. And I know that there is also a drive to make anti-racist training mandatory, at least for family medicine physicians. So it might not be as early as I want. I prefer it starts in kindergarten, but we are slowly getting there, I hope. There is a lot more work to be done.
So another effort is, one of the mainstays of medical education, undergraduate, graduate, faculty, is grand rounds. And there are efforts at certain institutions that require lectures and grand rounds to have diversified the images that they are showing. Also efforts to require lectures and grand rounds to include a discussion of disparities or health equity on the topic that they are talking about. So if someone's lecturing on hypertension, then part of their lecture needs to address the disparity of hypertension in communities of color. So that's just another example.
Thank you.
Hi there. My name is Jacob True, and I suppose I just have Siobhan's Siobhan, when you said that there was hesitancy in the BIPOC community about coming forward with health issues, and you explained some of the reasons behind that. How does the panel feel generally about a health delivery system that would be free at the point of service? Would that encourage folks to come forward, especially in cases where folks are worried about cost? And would that help in some regards? Thank you.
Thank you for that question. Yeah, cost is a huge barrier when it comes to healthcare. When you're usually, at least for me, there were times where we had to choose between paying rent or paying electricity. So having healthcare was almost like a luxury. I do think that it also needs to be more about education too, and building community awareness, that trust in your medical professional, whether it be your primary care or even if you're just going in to get your flu shot, you have to trust that person. And I found that the best way to do that is to go there. Of course, if you don't want to go there because you're distrustful, you kind of fall into this cycle. But I've seen some really good progress, especially in some of our community centers where it's about talking to each other, like either at church or in other organizations, and getting a recommendation.
because that can allow you to kind of let down your guard. Of course, cost is primarily the barrier, but if you're not comfortable with your doctor, even if that doctor is free, it's not going to, at least I don't feel it will better your health care.
Dr. DeVivier?
So the topic of hesitancy it's an interesting topic because there's no doubt that there's fear and concern in communities of color. I think that there's a lot of emphasis that's put on, for instance, the Tuskegee experiment, when really we can talk about present day events that probably have a greater weight on that fear. But with COVID-19, people spoke a lot about the fear of vaccination. And there were actually studies that were done that showed that it was not a question of hesitancy or fear. It was a question of access to vaccinations. And that's an important point because when we talk about fear or hesitancy, that puts the onus or the responsibility on the patient rather than placing it on the system that's responsible for access. So I think it's a really important distinction to make and to take it within context.
Dr. Crooks?
So I agree with everyone. Cost is a big prohibitive factor in seeking medical care. When I was a nurse, and I was a nurse for 10 years, some in Trinidad and some here in the US, I remember seeing patients here who had to choose between eating and eating and medication. And of course, eating will take precedence. Having a roof over your head will take precedence. So I do agree with a universal healthcare system because I believe it's a basic human right that everyone should have, that you should not have to worry about going bankrupt to see and get good healthcare. That being said, there is a lot of mistrust because typically when you see, I know when I first came to this country, my country does not have a lot of Caucasian people. So when I first came to this country, going places where there were a lot of Caucasian people made me nervous. And I think part of it might be epigenetics, which is where traumatic experiences that you or your people have experienced can actually help rewrite DNA, is a study that's being done actually. But I just know that historically, for people who look like me, being around a group of white people doesn't end well. So I think that having more BIPOC folk that people can talk to will help because you instinctively trust someone who appears to have a lot in common with you. And sometimes you have to search to find that commonality with patients, and sometimes it's as present as your skin. So I think having more representation will also help get over that hesitancy.
Next question will be from Mary Layton.
Hi, I'm reading this question that was texted in by Julie Davidson, Executive Director of Oregon Medical Education Foundation. She says, excellent presentations. Thank you all so much. What advice do you have for current medical and physician assistant students who seek to advance racial equity in medicine during their education? You've touched on the subject, but I thought you might have things you'd like to add.
Dr. DeVivier, you have the microphone.
Sure. So what advice can I give? I think that when it comes to, in my own experience, it's actually taken me some time to get to a point where I can speak publicly about this. And I think that's important, that you have to go at your own speed, that you have to not necessarily feel that you have to jump out and do it right away. Move at your own speed. And I think there's differences when there is, if we're talking about a student of color or a white student. Students of color, there's a great concern about the diversity tax and what, it's not, was not atypical for being a black anesthesiologist for me to have every black medical student or someone interested in medicine sent to me. And you feel compelled. You want to help. You want to do, and it's really easy. It's really easy to get burned out, or to be the one in the room that everyone looks to talk about whatever has to do with black health. That you're the sudden expert, and so there's definitely differences. I would say that for a white student is to not be afraid to speak up, to challenge, I think is really, really important.
I think it would have made quite a bit of difference if I had a doctor of color. And even a physician's assistant, or even somebody that could have helped, even growing up with medical professions in my family, if I would have had somebody who looked at me and I felt like they were there to help me. So I guess reaching out would be, my advice. Again, I'm not entirely sure what doctors can do when they're becoming a doctor, but I think that outreach is really good because a lot of the times that fear comes from lack of knowledge. And if we can bring more education into what the medical profession does for us as humans, then I think that can make it a little less scary.
Dr. Crook.
So to get involved, I do agree that you need to be ready because there is a lot riding on you. When people look at you as a representative of everyone else, it becomes exhausting. And you have to keep repeating that you're speaking for yourself. You can't generalize for everyone because everyone is different, just like it is with all other minorities. That being said, I think anti-racism training specifically would be of value because people have to learn to speak up, and especially when it's a white ally saying to another white person that this is wrong, they tend to get hurt more because when a black person says they perceive something as racist, it's so subjective. And if you're not part of the community that is receiving it, it can be dismissed so easily. So I think anti-racism training and implicit bias training would help. And I think also getting involved. There are many ways to get involved in minority groups. There are pre-med groups that are minority association affiliated. There are all these different ways to get involved and try to help mentor others, and also for you to make a difference in your community.
Do we have time for one more question? Please.
My name is Sharon Reed, City Club member. My question is, I'm wondering if there are policies or protocols at OHSU or OMG or other medical groups when a patient refuses care or treatment by a BIPOC medical professional and demands an alternative doctor. My brother is connected to Johns Hopkins Hospital, and I had a discussion with him, and I'm just very curious if there are some guidelines or protocols for handling that situation.
Sure. So at OHSU, we do have guidelines and protocols. It's made clear in the policy that folks do not have the right to choose their healthcare provider outside of certain circumstances. So establish, for instance, cases of trauma where a woman, for instance, would want to have a female provider. But of course, depending upon the emergent nature of the situation, that might not be able to be accommodated. So there are established policies. Quite honestly, it is a very difficult situation, and I've been involved in a number of national discussions around this because you have to balance the rights of the patient against the fiduciary responsibility of the caregiver, against the rights of the caregiver. So you have three things that you have to balance. That doesn't mean that because you're balancing them, they all receive equal weight. And that's a difficult conversation to have, and folks are struggling nationally to answer this through policies. But there's also a little bit of a different side to that question. So there are studies that are out that show, for instance, black men do better when they're seen by black physicians. There's a study that is out that shows that children in the NICU who are of color have a greater chance of surviving if they're taken care of by a black physician than they are by a white physician. So that would be an instance of someone who's asking for racial concordance in their care team. So we have to be careful when we're writing policies, and that it's always the danger of writing a policy is the unintended consequence of the policy. So there, that's where we are. Siobhan, quickly.
Again, I feel compelled to say, once again, I'm not a doctor, so I don't know the policies or procedures, but I know a cousin of mine right now is looking for a black female therapist, and she can't find one, and so she's not going to therapy right now. I just think that's a luxury to be able to demand a different doctor that's more to your suiting.
Dr. Crooks, we're running out of time. Could you have a response?
Yes, I would just say with OMG, they have a very strong anti-racist policy, and we have working on increasing diversity, equity, and inclusion. That being said, I cannot rightly say if someone is refusing me because of racism or because they don't like me. There is that part of it that's difficult to tease out, because a lot of people who don't want to see you, even if it's because they're racist, won't say it's because they're racist. So that is also difficult to pass out the racism versus they're really not getting along with you, because that can happen also.
Thank you all, and thank you, Dr. Crooks, also for mentioning implicit bias. It gives me an opportunity to say that there was a fantastically informative City Club program on implicit bias last year, and I would encourage everyone to look that up. This has been our February 25th, 2022 program, Racism and Medicine, and before we thank today's speakers one final time, I would like to recognize our diamond sponsors. Kaiser Permanente exists to provide high-quality, affordable healthcare services and to improve the health of our members and the communities we serve. More information is available at www.kp.org. The University of Oregon has helped Oregonians question critically, think logically, reason effectively, communicate clearly, act creatively, and live ethically since 1896. Get more information at uoregon.edu. Peace Health has been proud to serve Eugene, Lane County, and beyond as your hometown healthcare provider for more than 80 years. The Peace Health mission is to keep you and your family healthy, and you can learn more at peacehealth.org. Lane Community College transforms lives through learning. LCC provides comprehensive, accessible, high-quality educational opportunities that promote student success. And more information is available at lanecc.edu. And of course, we are grateful for generous support from the City of Eugene and Lane County. I would also like to acknowledge our Ruby sponsor, Johnson & Johnson, Lucas and Middleton. Support for the City Club comes from Johnson, Johnson, Lucas, and Middleton, a team of experienced, compassionate attorneys fighting for justice. If you've been seriously harmed by wrongdoing and need help, contact justicelawyers.com. Our Sapphire sponsor is Bennett and Dean Real Estate. Support comes from Bennett and Dean Real Estate, a full-service real estate brokerage offering a comprehensive range of services for buying or selling a Lane County residence, and more information is available at bennettdean.com. And today's gold sponsors, Headshots Eugene and Arcimoto. Thank you to our in-kind sponsors, KRVM 91.9 Radio, Pack Info and Simplified Computing, LLC, and Dotson's Photography. And a special thank you to public radio station KLCC FM 89.7 for airing City Club programs on Monday evenings at 7 p.m. Our programs are always available on our YouTube channel and Facebook page, as well as podcasts, and we invite everyone, members and non-members alike, to participate in our programs and to join us in person at our 2022 venue, the First United Methodist Church at 1376 Olive Street in downtown Eugene, or via live stream on our YouTube page. For more information, please visit our website, cityclubofeugene.org, and if you have a suggestion for a future City Club program that can help us to build community vision through open inquiry, please visit our website and submit your suggestion online. For next week's program, we have a discussion of adult mental health, trauma, and care, the second of 2 programs looking at mental health in Lane County. So please join us again on Friday, March 4th. More details and information about future programs can be found on City Club's website, cityclubofeugene.org. And finally, one parting thank you to today's City Club speakers, Dr. Derek Duvivier, Dr. Crystal Crooks, Siobhan Kenzel, and Kiana Kabuko for her first question. Thank you so much for sharing your knowledge and this important discussion with our community. This concludes today's City Club of Eugene program. Thank you for joining us in this community conversation. Please take care, stay safe, and we will see you next week. Thank you all.